This is Gary Kavanagh for Gript. I'm here today with Professor Theo Boer, Professor of Healthcare Ethics at Groningen Theological University. Professor Boer is an expert on the area of euthanasia and assisted suicide. From 2005 to 2014, he served on one of the Netherlands' 5 regional review committees on euthanasia. Those boards reviewed cases of euthanasia and physician-assisted suicide to ensure they were carried out in line with legal requirements. Once a supporter of Dutch euthanasia laws, now a staunch critic, Professor Boer, it is a pleasure to have you with us today.
Hi, good to see you.
So before we go into your own view on the Dutch law, could you give us a general rundown of what the actual status of the law is currently in your country, what criteria you need to meet, the kind of numbers we're seeing, just a general outline of it?
Yeah, well, we have a long history of debating assisted suicide and euthanasia since about 1969, so we have a more than 50-year period. We started tolerating it in the 1980s officially, so that is early too. Our first legal arrangement was in 1994, and the law we now have is dating back to 2002. The criteria are really very basic, and that is that there should be the request of a competent patient. There should be unbearable suffering. The suffering should also be without hope of improvement. And the doctor should have informed the patient about the possible alternatives. And then last but not least, the euthanasia should take place in a medically sound manner so that the patient does not suffer. Important is that, unlike in some other countries, we have both possibilities. We have euthanasia and assisted suicide. In euthanasia, of course, the doctor does the act him or herself. And in assisted suicide, it is the patient who drinks the poison. Interestingly, it is 97% of the patients and doctors who decide that it will be euthanasia and not the patient drinking the poison. That tells something about the degree in which the doctor is involved in the whole process. As for the numbers that you asked me, we started out basically in the 1990s and the beginning of this century by about 2,000 cases a year, and that remained level for a couple of years until then, right in the middle of about 2005-06, the numbers started going up, and we are close to 7,000 cases per year now. And that is an important increase if you reckon that the overall mortality has remained rather level during that period. So at the moment, we have about 4.5% of all deaths are preceded by euthanasia or assisted suicide.
And is there a sort of average person who's likely to avail of this? I mean, is there a particular demographic? I imagine age plays a particular role, but are there other demographics like those with mental health issues, or is it concentrated primarily on age?
It is primarily concentrating on the pathologies, the illness of the patient, and that still in most cases it is a terminal disease. Although that terminal diseases was in the beginning, it accounted for about, I would say about 92% of all deaths through euthanasia, and that number has gone down. Not only cancer, but increasingly also neurological conditions, terminal heart failure. But then very interesting, of course, too, is people who are not expecting a soon natural death. I think in the beginning it was really the context of acceptance of the euthanasia law was for people who were dying anyway, and that euthanasia was kind of the last resort to prevent a terrible dying process. Whereas now for a considerable number of people, and still not the majority, but I would guess about 10%, euthanasia is a way to prevent a terrible life. So these people have a certain amount of natural time span. It can be between 2 years and 20 or 30 or 40 years, especially in psychiatry. We have psychiatry cases I think about 80 a year. That has remained level now for a couple of years. We have dementia, of course. People have a life expectancy of maybe between 3 and 7 years, whereas about 200 a year, with a tendency to go up to, and there's all kinds of very specific conditions, such as people with autism or people with blindness. It's just a couple of people a year, maybe 10, 20, that have these special conditions that you probably would say were handicaps and not an illness. But that number is going up. And also interesting is that we have an increasing number of what we call euthanasia for two, where it's two people, of which one normally is terminally ill and the other is not, but is, for example, chronically ill. And where the people decide that they will have euthanasia together. That number is about, I think, about 35 people a year.
So some of the conditions that you mentioned there, when you were talking about the law and you were talking about the need to show that the suffering was unlikely to be alleviated, some of those conditions that you met would seem quite difficult to show that to be the case. Has there been any debate about this, or is this simply a low-level trend that's been sort of developing and hasn't really been debated yet?
Well, that's a good question, because, you know, the criterion that the suffering should be unbearable, I think in effect is, first it is a very subjective criterion, because whether or not I experience my suffering as unbearable very much depends on my biography and my values and my worldview and my past. And now the point is that a patient, so to say, has to make sure that their doctor accepts that suffering as unbearable. So what you get is that in some cases, patients and doctors are getting involved in some kind of a play where the patient tries to convince the doctor, and sometimes they succeed and sometimes they don't. But, you know, it's a very subjective criterion, and I think it's very hard, and it is maybe even inhuman for a doctor. If a patient says, "Doctor, please, this is for me unbearable," what kind of a doctor are you if you say, "Oh no, your suffering is not unbearable. I don't think it is unbearable." So it puts, so to speak, doctors in a very poor, dire situation, that they have to contest the seriousness of the suffering. So which in end effect means that if a patient insists and insists and insists, then the doctor will have little other options than saying, okay, if this is what you want, then I assume that this is unbearable.
So looking at the actual provision of these services, is it the case that this is a service just offered at a general level across the country, or are there specialized clinics or practitioners who focus primarily on this?
Well, interesting that you use the term offered, because we still assume that in the Netherlands euthanasia should not be offered, but should be requested, and the initiative on the part of the patient. Now, I know of cases, and I don't know whether it's in 2% or 12% or 22% of the cases. It's very hard to do any serious research on this, where the doctor is the one who says, well, given your condition, would euthanasia be one of the options that you would like to consider? So, but talking about offering euthanasia is a very sensitive subject. It should come from the patient. Now, as for your question about euthanasia clinics, there is actually one organization that is previously known as the End of Life Clinic and now known as the Euthanasia Expertise Center. It is not a clinic. They have, I think they have a house, a building with one bed, but this really in reality is teams of traveling doctors who in a central place in The Hague, the capital, they get the euthanasia requests, and then a team of normally a doctor and a nurse visit the patients on site at their homes. And then once or twice or three times and then the second doctor gives their opinion, and then the euthanasia will be performed in the patient's home. So there's not a specific clinic where you go to and where you enter in a living condition and you're buried out carried out a dead. Nothing of that kind.
So you previously, if I don't misunderstand your position, had been a strong supporter of these laws, and obviously you've changed your position now. But why? What were the reasons behind your initial support for these? Had there been particular personal circumstances or arguments you'd heard that you found persuasive?
Well, there's one thing that I should add, and that is that I never, unlike some people who would like me to be that, I have never been a strong supporter of the law. What I've always said, even when I was invited to be part of the euthanasia review committee, that assesses each euthanasia case in hindsight. When I entered that committee, I did say to the chairperson that I was critical about euthanasia, but then as a Democrat, I think that it is a good thing that euthanasia, if once it is allowed, that we do have a transparent system of control. So, and of course, I can imagine, I am not a principal opponent to euthanasia. My position has always been and still is, euthanasia could be okay, but just like violence in war, it should be an exception. It should be a last resort. Now, what made me change my mind is that I have actually witnessed that euthanasia increasingly has become from a last resort kind of a default option. And there is research that we have done that really affirms this outcome, this fact. This year we published an article in the British Medical Journal where we saw that there's what we call practice variation in euthanasia, which means that in some regions in the Netherlands, there's hardly any euthanasia, whereas there's districts in some cities, especially in the western part of the country, where euthanasia accounts for 1 in 6 or 1 in 5 deaths. So, and that being the fact, I can no longer believe that if 20% of the people die through euthanasia in a certain urban district, I can no longer believe that that is the last resort, that is the only option. Clearly, something is the case in the Netherlands, and that is that euthanasia, the euthanasia law has become to function as a kind of an offer, as the kind of a, I think the supply has created demand. Now, someone may say, and some people ask me, is it spinning out of control? I think it's not, because this is what people want. But I think that once you legalize assisted dying, the fact that you have legalized it will do something to the way you consider living and dying, you see. And that is what people accept. And but what I tend to say to Ireland, for example, or Great Britain, that is, once you legalize assisted dying in any form, and I would say that if you do it, I do prefer assisted suicide rather than euthanasia. But if you legalize it, be prepared that you will be ending up like the situation in the Netherlands in 20 years from now.
So it sounds, and not to put words into your mouth, you're saying that your primary issue was the normalization of the process that seems to have taken place after the law was passed. Looking at that issue of normalization, of it becoming just a standard part of the equation, do you have any idea as to why that has been the case, or why you think that's happening?
That's a good question. Really, and I think I have a hard time answering it. The point is that euthanasia by pro-choice organizations, we have the biggest euthanasia association in the world, both in absolute numbers and in relative numbers. And, the point is that they continue day after day to portray euthanasia as the most dignified death. And the other thing is, and that you can see that in campaigns in Great Britain and Ireland, they continue to portray a natural death as a potentially atrocious, terrible death. Now, that does happen occasionally, but that story was much more true in the 1980s than it is now. The palliative care has become so much better, especially given the fact that we also have some palliative sedation, that the prospect of a terrible natural death is not nearly as realistic as it was in the 1970s and 80s.
So when you were saying about, when I had said offering these services, and you're making the point that the patient must request it and it's a sensitive issue, what is the general tone of media and government towards euthanasia? And I ask this question just with an eye to, is this something that is presented to the public as an acceptable, just an acceptable option? And is that influencing people to bring it up themselves? But what I'm really asking here is, we're talking about people having this choice, but is this the only choice really talked about in popular dialogue, or are alternatives like palliative care or whatever may be required also a big part of the picture? What is the cultural narrative like?
Well, the government itself is generally very low profile about euthanasia. They will seldom say something positive or negative about it. What they will do is they will refer to the existence of euthanasia review committees that review every case in hindsight. So there's not much discussion. Well, but then on the other hand, in the media, the default paradigm, the default narrative of euthanasia is, as it is in many countries, it is one in terms of dignity, it is in terms of bravery, is in terms of compassion, it's in terms of self autonomy. That is really the main paradigm. And in the book that I issued, as I have it here on my desk, it is Living with Euthanasia. We published it just a week ago, and there we collected 43 stories of people who had experiences with people who had euthanasia. And there the interesting thing is that apart from a number of hallelujah stories about euthanasia, there's also a number of people who are ambiguous, and even some people who are outwardly bitter about their loved one having euthanasia. So what we do and try to do in my profession as an ethicist is at least to keep the debate going. Because what you will see is that once euthanasia is legalized, and especially in the Netherlands, where we are kind of a laboratory with much international focus on this. So the standard option here is, don't criticize what is going on in the Netherlands. Please emphasize that everything is going as it should. And that is paralyzing. But because I do not contest the law at this moment anymore, but what I think is absolutely needed is that there should be an ethical debate about, as you say, about the alternatives, because dying a natural death can be a really wonderful and a really enriching experience. And we have many stories of those, but they don't make it into the media.
So I know, at least in Ireland, when we're looking at proponents of these topics, or proponents of the legalization of these topics, there's generally two arguments made. The firstly is the bodily autonomy issue, that this is a person's choice and you don't have the right to stop them. That would seem to refer more, of course, to assisted suicide than euthanasia, which obviously involves others. And the second is a compassion-based argument, that this is, an inhumane thing to refuse someone. The example in Ireland that's often come up is, if there was a dog in pain like that, you wouldn't force it to live. How do you square the circle here? How do you come up with a policy that deals with those issues and accepts that some people are in legitimate and significant suffering that is unlikely to be alleviated, without risking contagion to the wider society? I mean, is it a case that there is a workable solution here that works for everyone, or is it simply a case that some people are going to suffer regardless of the option here?
Oh, that's a very good question. I think compassion is very important, and we should concede, we should affirm that there can be suffering that is heartbreaking. But, and as in any ethical problem, we should keep in mind what are the different alternatives to alleviate this suffering. And yes, if assisted dying would be the only solution to prevent heartbreaking suffering, but the only, not the euthanasia as a fashionable death, but euthanasia as the only way to prevent a terrible death, then I would suggest that could be a good thing. But, you know, I think we need to focus more on the positive sides of the enormous advances that have been made in palliative care. Really, they are groundbreaking. There has never been in history a time in which euthanasia was so not necessary as in 2021. So, but then still about the autonomy paradigm, should I not have the right to decide about my own life? Well, as a Christian, I don't think so. But as a citizen, I think, yes, you may. I will not, I should not force anyone to go on living. That would testify disrespect. But then I think if we spell autonomy with a capital A, then we should insist that it is not the doctor who kills, but it should be the patient who takes the initiative, and preferably that the patient should do the act themselves. So um, suicide has occurred in all ages and for some good and heartbreaking reasons. But let us not romanticize that situation, and let us not regulate it too much, because when we regulate it, it entails a suggestion that this is what all of us together think is the best way to die. And I think we should avoid that impression at all costs.
So when discussing this topic, it's natural to focus primarily on the patient, the person being impacted. But earlier when you were talking about euthanasia and the input of doctors, how do doctors feel about this? It seems like something that could be argued to quite fundamentally change their relationship with their patients. And obviously there will be arguments there that what you are doing is in their best interest. But I'm just curious, has there been any studies done into medical professionals in your country, and has this had any impact on them professionally, psychologically, or just culturally?
Yes, there has been done some research on how physicians experience providing euthanasia. I think there are three groups mainly. One is a group that says I will never do euthanasia. The alternatives are so convincingly available that or I don't do it because of my worldview, my ethics, or my professional view. That's one group, and I think there's about 1 in 5. And this number has gone up slightly in the past year. So there's a number of doctors who say that I will no longer do euthanasia. I know several people in my colleagues circle that have made this decision. Then there's, on the totally other side, there's the group that are, for example, connected to the Euthanasia Expertise Center. And they provide euthanasia between 10 and 50 times a year. For them, it is a matter of helping patients, the more the better. Not that they are fond of killing, of course, but that just like a doctor, a gynecologist may be proud of delivering many babies, some doctors may be relieved that they have helped many people to have a dignified death. And then there's the biggest group in between who say that they can imagine making this exception, but they dislike it. They think it's emotionally stressful. They want to avoid it as much as possible, and they are happy if this cup passes them by.
So looking beyond your country, are there any countries that you think has implemented a better way of doing this, or is heading towards that kind of implementation? Anywhere a country could look to, for example, as to the quote unquote right way to do this?
Yes, that's a good question. It's a question of conscience. I would opt for the system in Oregon. Not that that functions so well in every respect, but you know, if, as I said, if you spell autonomy with a capital A, autonomy is very important in Oregon, and they have a very simple law actually, and it says that you should be in close to a natural death, and I think that is a sine qua non. That's an absolute condition. Do not offer euthanasia to people who have no death expecting them in the near future. That's the one, and the other thing is then that the patients should do it themselves. And in the Netherlands, we made this switch towards having euthanasia very early, from actually 1969 on, where there's this massive involvement of the doctor. I think that is detrimental to the physician's work, and it's detrimental to a patient-doctor relationship, because it puts the patient, it puts the physician on a pedestal. It puts the physician in a position that formerly was only for the priests, namely as the one who decides about who lives and who dies. So yes, I would say Oregon, but the best is probably to keep tragedy tragedy, and to respect the choices of people who want to end their lives themselves. I think actually I don't want to make any suggestions here, but I think for those people who are intelligent and who have internet, and they will find the ways to end their lives in a humane way, and don't ask too much involvement of a society, let alone of a healthcare system.
So just to close on, Professor, we've talked about where things are currently in your country. Where do you think they're going to go in the future? What do you think the trends are that we're going to see?
Well, what we saw in our research about the numbers is that the low incidence regions where euthanasia is relatively seldom, there the numbers are going up. So I still see a large growth potential. Then there's another possible growth potential, and that is euthanasia in people who are not competent or are no longer competent. We have now had a recent court case where a physician was acquitted who killed a patient who was no longer competent, but she had written an advance directive some years ago, and they killed her on the basis of this advance directive, whereas at that moment itself, this woman was not able to confirm her wish. Actually, she seemed to not be okay with it. And then the physician said, we have to respect her advance directive more than respect her present will. The Supreme Court has acquitted the physician from all charges, which means that in the future we will see more euthanasia cases of dementia patients who are no longer competent. Now, I don't have a glass ball to watch, but I think that in the end, we will see in a couple of years, we'll see where situations where people will say, why is it that Mrs. Johnson, who has dementia, and who has an advance directive, why will she receive this dignified death, whereas her neighbor, Mrs. Smith, did not have this advance directive, but she is suffering even all the more? Why should we let Mrs. Smith, why should we punish her for not making an advance directive, whereas Mrs. Jones can have this ideal or this dignified death? I think there will be court cases like this, but maybe it'll take 10 or 15 years, but I can see it at the horizon.
So you would be, that nearly sounds like a sort of lives not worth living distinction being put onto people who've never made that classification themselves by the state.
Well, life not living is of course, that is reminiscent of Nazi vocabulary, which I do resent, so I reject that. But yes, we have, for example, this law proposal now in the Netherlands, and it is under scrutiny now, but there's some reasonable chance that it will be accepted, and that will provide euthanasia to anyone over 74 who wants to have euthanasia regardless of their medical condition. Now, the thought behind this is clearly that if you're my age, I'm 61, if you're my age, you have to call 133, which is the suicide telephone line in the Netherlands, and people try to keep me from committing suicide. Whereas when I have reached the age of 75, sorry, from 75 on, society would all of a sudden say, well, in your case, we think it can be rational to kill yourself. And I think that is, yes, that is an underlying evaluation in this completed life act, as it is called, namely elderly people. It's no problem if they want to be killed. We will only be suspicious when it's younger people.
Professor Theo Boer, it's been a pleasure to talk to you.
Thank you.